Hi, it worked the first time. That's crazy. Welcome to Mad Medicine with Miss P. This is going to be real quick. I know I say that every time and then it ends up being longer, and that's, of course, one of my pet peeves. Today, I'm just running crazy late. I literally should be walking out the door right now. I don't know how I worked 5 days a week since I was 14 and still got everything done, and it doesn't even matter how early I get up. It's just ridiculous. Anyway, I'm just going to run through some antispasmodic slash anti-seizure medications. And a lot of the things I teach about medications is kind of like so you can look at the medication list and already know what you're dealing with. And I tell you guys that all the time. When I go to get report, when I was working on the floor, when I went to get report, I would, if the nurse was busy and had some running around to do, I would read the first paragraph of the H&P, the last paragraph of the H&P, maybe skim through some of the middle where they talk about labs, but mainly I would go straight to the med list. Straight to the med list is what's going to tell you everything. When you really know your meds, you'll know everything to know about your patient. When you see a heparin drip and that they got nitro or they're on, 5 different cardiac meds, they probably came in with AFib or an MI. If it's heparin drip, most likely an MI, right? So your list of medications will tell you a lot about your patient. So when I see a med list or talk to a patient, I get their list of meds, I already kind of have an idea of what's going on is when I see, certain antispasmodics. So the most common ones is Dilantin, Keppra, Tegretol, sometimes Phenobarb. Phenobarb's not even in my book, which is crazy because it's a 2021 book. I guess they don't give Phenobarb as much anymore, but you'll still see it in some of the long-term care facilities. So when I see those medications, I already know there's a seizure history, even if they had one when they were 19 and they just keep getting treated for it because it's not worth the risk of having another seizure, right? Why are seizures so risky? First of all, you're going to drop usually like a rock to the ground. You can hit your head or worse and, have a bigger issue, or you could be driving or on a ladder or, whatever you're doing to where it's a huge risk. And a lot of states don't even let you drive for a year from your last seizure or 6 months or something to that effect. So it's a big deal having seizures, not just because it's so dangerous, it can be dangerous for others as well. But when I see Dilantin, I already know they have a seizure history. So I want to look for a Dilantin level, make sure that they are compliant with it when their last seizure was. Those are the things you always want to know. Keppra, same thing. That's a level as well. And Phenobarb, Tegretol, those all kind of have blood levels because, they can take it every day. But if it's not a high enough dose to have a therapeutic blood level, well, then what's the point of doing it? So I talk about these in kind of relation to gabapentin and Lyrica. When I see somebody on gabapentin and Lyrica, I kind of have an idea that they not necessarily have a seizure disorder as much as they might have chronic pain, and it's because they work differently. Now, I know it's tricky, and some of you, specifically certain people who may or may not have published a paper on the subject may want to argue with me, but for teaching's sake, for kind of just on the floor, basic knowledge of what I have kind of realized over the past, I keep saying 26 years, but I actually did the math the other day. And next November will be 30 years I've been a nurse, which seems insane because I'm only 24. But at any rate, when you see Dilantin, Keppra, Phenobarb, Tegretol, there's a history of seizures. When you see gabapentin or Lyrica, I know if you look them up, it says action unknown. It says the same thing for Tegretol. It says unknown, but appears to decrease the polysympathetic receptors. So you're like, okay, well, what necessarily does that mean? They work differently in different places. Some, kind of work in the brain, the spinal cord, or at the synaptic, peripheral areas versus gabapentin and Lyrica. And I know if you look them up, it says action unknown. But what I'm guessing, what makes sense to me, what I've seen overall, and what, some recent studies have shown, because like our anesthesiologist said, it goes to, like I said before, different, symposiums and talks and conferences to stay up on this stuff. And what they found was that gabapentin and Lyrica sort of work, like I say all the time, it's kind of like, shh, don't tell mom, right? So they kind of work peripherally to stop the brain from receiving those painful stimuli. So gabapentin is GABA being the number one transmitter in your body. And if you pent it up, you're stopping neurotransmission. Now, does it necessarily work that way? I don't know. But if you're going to name it that, this is the way I'm going to teach you in a way that it may stick in your brain and it may make sense when you get there. So if someone's coming in for a painful procedure, our anesthesiologist will sometimes order 600 milligrams of gabapentin before that procedure. Now, does he think that patient's going to suddenly have a seizure with no history? No, but before their surgery, they'll order that 600 milligrams of gabapentin because afterwards it may help stop those pain receptor sites from giving that signal to the brain saying my belly hurts or my ear, hurts. So we'll give those ahead of time to stop postoperative pain or decrease postoperative pain. And that's kind of how gabapentin and Lyrica work. And that's why you see so much in chronic pain patients and, those clinics that give those medications. They don't give Dilan, they don't give Tegretol, they don't give Phenobarb, they don't give Keppra. They give gabapentin and Lyrica because it works in a different way to stop that spasmodic or those receptors from transmitting that knowledge. So the other medications you'll see around seizure activity is Valium and Ativan. So Valium is a skeletal muscle relaxant. It's probably one of the best medications you can give immediately to relax those muscles from being able to spasmodically contract. Now, yes, it's used for other things, and I know it's like anti-anxiety and that sort of thing, but the truth of it is it's a true spasmodic in the sense that it is a skeletal muscle relaxant. When my mare severed her neck and then the idiot vet that I stupidly called because I didn't know any better because I was new to the area, insisted on giving her lidocaine in the open vessel area as if she's going to give a crap with her neck hanging wide open if you try to stitch her up. So that lidocaine went systemic immediately. She dropped like a rock and started having seizures. And what did we give her? Valium. So that would be, ideal to stop that muscle firing immediately. Now, Ativan is given also, and it says that it potentiates the action of GABA, especially in the limbic system and reticular formation. So Ativan will work, also depending on the type of, I don't know, full-fledged tonic-clonic, this massive grand mal. Your Valium is probably your best bet, assuming you have IV access. I don't necessarily know. I haven't been involved in a lot of seizure activity. I've seen some more of my friends than actually on the floor because most of our patients hopefully are being treated and maybe their levels got a little low and they may or may not have had one. But for the most part, if you're treating a patient with seizure activity, it's really just a safety thing. Just hold their head and try not to let them get hurt. If you have IV access, obviously you're going to give Valium, Ativan, whatever's ordered. But as far as seeing a list of those medications on their MAR and knowing what you've got. So if I see a patient that's on, oxycodone or, Dilaudid with gabapentin and naproxen and all that, I know they're a chronic pain patient. That's where the gabapentin comes in. Now I see a long list of, random medications and then some Dilantins thrown in there. That's a seizure patient. There's really no other reason that they would have Dilantin. It says it works in the motor cortex and may increase AV conduction. I don't think that anybody's out there on Dilantin to increase their AV conduction. Maybe. I mean, anything's possible. Keppra, Phenobarb, Tegretol, and those meds you're going to see because they have seizure activity. So you can already look at that list of meds and know what you've got. And I do that to this day regularly. Maybe a couple times a week as a patient's giving me the list of meds and they say Tegretol, they give me the milligrams and I'm typing it in. I say, okay, when was your last seizure? I already know they have seizures. That's what it's for. There are a few out there that are for other things. There might be one for like migraines or something like that. I can't think of anything right now. And good Lord, there's new medication starting up every day. Every day you turn around, I have to type into my phone as they're telling me or spelling me a medication that I've never heard of, especially for, diabetes. But for the most part, those are the medications you're going to see most frequently. And there's probably a couple more that I forgot about. I don't do much prep for this. I just go off on what I can remember. And like I said, this is really for you nursing students getting out there and just trying to get a grip on, how to care for your patients and what to expect your first day, taking care of somebody or your first, kind of first couple of years trying to get your foot in the door and learn how these things work. But for the most part, that's what you're looking for. And like gabapentin and Lyrica, I don't even believe that they have drug blood levels. They might. I don't think I've ever heard of one being checked or anything like that. But the Dilantin, Keppra, Phenobarb, we want those drug levels, making sure that they're taking them, make sure that they're getting them, and making sure that it's a therapeutic level to help decrease the risk of seizures. So that's really all I've got because I have got to get out of here. I don't even have a pet peeve. Not that, I have a pet peeve. I have many, many pet peeves. I should never hear what's going on inside your mouth when you're chewing. That's never a thing somebody around you should ever hear. I'd rather hear your stomach growl or flatulence. I'd rather hear than what's going on in your mouth with your gum. And for those of you that insist on popping your gum in my presence, one day, you're going to regret it. Ask Anita. I fished hook her, got her in a headlock, and pulled her gum clean out of her mouth. Now, yes, she, of course, put another piece back in quickly to spite me, but that's what my good friends do. I guess we can talk about antibiotics next time. And I did want to talk about potassium and the medications that work to help drop that. That's always a good thing to know. But that's really all I got because I got to go. And that's the extent of my pet peeve. That's all you get. And I'm going to bet you, since this stopped blinking, that it is not going to work at all. Maybe I turn it back on, turn it off. And as always, face your fears, forget your failures, follow your faith. Oh, maybe this will work. Nope, it stopped blinking again. Son of a biscuit.